I don't think it's new. I think this has probably been around for forever. It's been around as long as all the other mental health issues. But I think it was never really looked at as an eating disorder. I think it was always just looked at as a picky eater. And people didn't really realize the severity of this issue, how much it can affect your daily life, your ability to function, your health, your family. I don't think that was really looked at until recently.
You've arrived at the Mental Health Spotlight podcast with therapist Caise. This series is on ARFID, which stands for Avoidant Restrictive Food Intake Disorder. It is a clinical eating disorder. There are several types or origins of ARFID. There's lack of interest in food, sensory avoidance, and fear of aversive consequences of eating. ARFID is not picky eating, but persons with ARFID have food restrictions, fear or avoidance of certain or many foods. This impacts getting enough and appropriate nutrition, which eventually leads to physiological, social, and mental health dysfunction. Unlike other eating disorders, ARFID is not typically associated with body dysmorphia or a desire to change one's weight or appearance. It is important to note that having ARFID is already a risk factor for other eating disorders, another reason to treat ARFID quickly. ARFID affects both children and adults and is across demographics. Similar to other eating disorders, persons with ARFID often have a comorbidity to other disorders, including anxiety, panic, and OCD. ARFID can be treated and persons can adopt adequate food behaviors and intake with the support of a professional team. This process is not linear and it can be lengthy, so early intervention with a professional team is imperative. Today's fabulous guest is Jaime Haumesser, a licensed professional clinical counselor with a clinical supervision designation. Her experience in mental health is vast, with almost 20 years in practice, focusing on trauma, mood disorders, anxiety, ADHD, and chemical dependency. For the past 9 years, she's been specializing in treating eating disorders as the clinical director at the Whole Institute in Cleveland. I know Jaime professionally and personally, and I can attest to her voracious seeking of knowledge. She is continually vetting out new and alternative methods to support client wellness and recovery. Her education and insight pair wonderfully with her warm, genuine, and individualized therapy approach. I am elated that today she is sharing with EDM3 her clinical acumen along with her practice experience and also allowing us to learn from her own personal exploration into ARFID with her own child. She is an asset to the eating disorder community, her clients, and this very appreciative podcast and podcast host. Jaime, welcome so much for being here. I am smiling from one side of my mouth to the other because I'm so excited about where we're going to go today.
Thank you for having me.
Absolutely. Well, you and I have shared in a lot of conversations about many aspects of disordered eating and mental health. So I am stoked that we're going to get to dig deep together and hopefully provide some more information about ARFID and maybe debunk it and also provide some resources too.
Yeah, that sounds great.
So before we get in there, I kind of already talked a little bit about who you are, but tell us a little bit about who you are in the field and how this even has anything to do with what you do on a day-to-day basis.
So I work for the Hall Institute, and I've been a therapist on the outpatient basis for 8 years now, I believe, with the Hall Institute. Also, about 3-ish years ago, I became clinical director because I do enjoy supervising and teaching as well. So I do both see clients and supervise.
And because you're amazing, you're an amazing clinician. There's that.
Thank you. And I really ended up feeling like eating disorders was something that really resonated for me. I met Anne at a training about 8 years ago. And, just in listening to everything that she had to say was really interested and intrigued. And she gave me some great training along the way. And I just found that it was my niche and I love it. So I've also had some of my own personal issues, which we can talk about a little bit later, with my own family and my daughter who also had ARFID. That also fueled some of my passion for this work.
So you're going to come to us with this fabulous professional perspective, but also a personal one.
Yes.
Yeah. And that makes it richer. And that's why we're so happy you're in this community, because what an asset we have with you.
Thank you.
You were here before me. I say that as if I was here waiting for you. You came before I did.
Not too much longer, but a few years.
I'm following in your footsteps still. I guess we'll just kind of get right to the first idea is there's other podcasts in here about what ARFID is and some specifics that way. But How does someone find you? How do you end up sitting across from a person who potentially or diagnostically has ARFID?
think there's multiple avenues. One that I think is the most common is self-referral. We get a lot of clients who are self-referred. They just do a general search for outpatient eating disorder clinics or eating disorder treatment. They find us that way. There is also the potential for us to get clients who are coming from a higher level of care. So we might be getting a referral from another treatment facility. They may have started at residential or PHP and then stepped down to IOP and then on to us. And then we do get some referrals from other professionals as well, such as schools or doctors or other therapists who maybe don't treat eating disorders. In fact, I think that's probably a really common scenario that we get referrals from another therapist who's doing work with a client, maybe for anxiety or depression or other issues, and then along the way discovers that this person has an eating disorder and they feel, that that's not necessarily within their scope of practice, and then they refer to us.
That's a good point. So, disordered eating alone has its own scope. What we've discovered, even among our own colleagues, is that ARFID has a niche as well. It has its own little corner that everyone is not worked with and is fully aware of.
Right. Especially because it is so new that I think we're really all still learning. This is so new. The research is really just now starting to come out. Resources are really just starting to pop up. So we're all new to this.
I'm going to already go for the tough question. What the heck? Here it is. Do you think that it is new, or do you think it is being diagnosed newly? What are you seeing in your clients?
I don't think it's new. I think this has probably been around for forever. I don't know how long, but it goes back a long time.
Mm-hmm.
I would guess it's been around as long as all the other mental health issues that are out there. But I think it was never really looked at as an eating disorder. I think it was always just looked at as a picky eater. And
Yeah.
people didn't really realize the severity of this issue, how much it can affect your daily life, your ability to function, your health, your family. I don't think that was really looked at until recently.
Yeah. And you kind of leaned into the idea that picky eating is one category, but you talked about the function change and acuity. Is that the difference between I have a picky eater and I have a child that or a person that could have ARFID?
I think there's a couple different things. One would be, yes, it starts to really impact your daily life. It starts to impact your ability to function in other areas. It's getting in the way of maybe social relationships, maybe work functions, school, just doing things that your peers typically do. But I think there's also the piece to it of, there are people who are picky eaters, but they still manage to get enough nutrition throughout the day. They might have kind of a narrow palate, but they eat enough to kind of get through and they're doing okay. But I think with ARFID, there's usually either they don't eat a lot volume wise, or the most common scenario I think is they only have a handful of foods that they feel comfortable eating.
Mm-hmm.
So it's the amount of food and the types of foods are extremely limited.
And that's why then you see the nutrition changes and also the resistance in the social settings and the body changes.
Right. And a lot of times it results in some health issues if it's gone on long enough.
Absolutely. What else could this be caught underneath label wise? What is something else where someone might be calling it this for a while and all of a sudden we go, wait a minute, no, this is actually ARFID?
Yeah, I see that a lot. So I would say anorexia would be one thing. I think it's been mislabeled anorexia quite often. And the difference is that with anorexia, there's body distortion issues. There's a person who really has some issues with how they see their body, and they have a fear of weight gain. Our clients who have ARFID, they don't have a fear of weight gain. They don't have the body distortion issues. Most of the clients who come see me with ARFID actually want to gain weight. They actually, or if they're
Yeah,
not underweight, don't have a fear of gaining weight. They want to eat more foods. They just feel like they can't.
that's a great point. I'm glad you brought that up, that there's a distinction.
So that would be one common scenario. A lot of people think it's just anxiety, can be kind of lumped also in with autism spectrum disorder. I think a
Yeah.
lot of times we see there's a high comorbidity there with
Mm-hmm.
people with autism. And so sometimes in treating autism, it's just kind of lumped in with the rest of the autism treatment and not necessarily looked at as a separate component.
And then that probably means they're not getting the specific care that would treat that aside from the other things they're learning.
Right. Exactly.
You mentioned something earlier today. We were talking about clients in one of our conferences, and we said sometimes how ADHD can affect appetite and attention towards food. And do you see that too, that someone with ADHD might get mislabeled and this might get missed as well?
So often, yeah. With ADHD, I think there's a couple different components that can really contribute to the development of ARFID. One thing would be that there's often sensory issues that go along with ADHD. It tends to just kind of be a comorbid issue.
Mm-hmm.
The other thing is that oftentimes people with ADHD just are not really in tuned to their body cues. They're very much in tune to, you know, 20 things going on outside their body, and their mind is moving from one thing to the next to the next.
Right.
They're not necessarily focused on the messages that their bodies are giving them. So they may not be tuned into hunger cues. They may not have much of an appetite in general. So if you don't have that drive, your stomach and your body is not telling you every 3 hours it's time to eat, you could easily forget to eat, and then it becomes habitual.
Yeah.
So there's different components with ADHD that I think could be very much contributing to ARFID.
Yeah. And from what you're saying too, if you put those two together, that we're talked a lot about comorbidity, having two things at once, you've really got a challenge because eating is
Right.
going to be challenging on two levels.
Right, exactly. And that was the case with my daughter when she was a baby. She never really had an interest in eating. There was so many other things she'd rather be doing, and she was such a busy little person. She didn't want to stop moving ever. So to sit still to eat was just extremely difficult for her. She learned how to get herself out of her high chair at age 12 months. She just would unstrap herself and flip right over the tray and go running. And
Awesome.
it was so challenging to just keep her still and keep her fed. And then there were sensory issues and she would gag a lot. I don't think she really was in tune to her hunger cues either.
And so in her case, and we talk about some of the other podcasts, the different types of ARFID, there's not a one size fits all. And speaking about your daughter's experience, which of the labels or the features would she have had?
I think it would be a combination of a lot of different things. One being the ADHD, just kind of the lack of sensory cues,
Mm-hmm.
interoceptive issues.
Yeah.
And then there was the anxiety piece. She also has a lot of anxiety. And I think with the anxiety and the ADHD, she has a lot of sensory issues. So that was huge as well. Quite a few things were working together to create the perfect storm. And I think that's the case for most of our clients. Most of them are not just straightforward one contributing factor. I think there's multiple factors that tend to come together.
Yeah. And a lot of times when I'm working with a family, especially with young people, they'll say, we did see that in the past, but it wasn't an issue in the past. It didn't really cause a problem. But now that we had an event or a culmination of things going on with this young person, and now we have ARFID presenting, now we see how all those things have fit in and they start to
Right.
make those connections.
Exactly. So like in my daughter's case, she was pretty much born with this profile. We've struggled with this since birth, although she's doing amazing now. I would say she's pretty much completely recovered.
Fabulous, by the way.
Thank you. It's very exciting. With other clients that we've seen, I think they had maybe some of the underlying contributing factors that have always been there, but then there was a precipitating event that just pushed them over the edge into ARFID.
Yeah. So in other words, it was there waiting. It just took something almost like an autoimmune for it to surface and come out.
Yep.
And in a way with these young people, I guess it could be a bit of a blessing in disguise because then they get to address in the family the things that maybe shouldn't be laying in the background that we really have to help the young person with. And then this person or the adult gets to work a little deeper and be less vulnerable to it.
Right. It is an opportunity. If we can reframe it into that, it can definitely be an opportunity to explore a lot of issues that needed some work anyways.
And that's what we do, right? We are these positivity people sometimes. We try really hard.
That's true.
I can make any glass half full. Just give me a minute.
Right. You have to be in this field.
Yes, absolutely. You mentioned your daughter, and we have talked a little bit anecdotally about young people. And there's two things I'm thinking about as we sort of start looking at current trends. Young people in ARFID and what we've noticed as a change. And you mentioned anxiety being underlying so much. Did COVID and the anxiety of our global culture, do you see those things, the COVID impact and young people being diagnosed?
I have actually seen a bit of an uptick in the amount of clients we're currently seeing who have ARFID. I believe that there's a chance that COVID was a contributing factor because during COVID there was such an increase in anxiety for so many people for a lot of different reasons.
Mm-hmm.
And so, obviously, as we know, as anxiety increases, some of those feeding issues can increase as well. So, I do think that is one of the factors for sure.
Yeah. I think in all mental health, we just can't help but bring it up at least once.
Right.
I
Yeah.
know in my side of the practice, I have had younger kids with ARFID. I've had adults and young adults too, but very young children, 8, 10 years old, that again, a precipitating event happens. And then we have a case of ARFID. So I don't know if that's something we're seeing more again, or if that's always been there, but it warrants why we have to have these conversations because our young people are so vulnerable at a young age.
Right. And what's interesting is I've actually seen a lot of older people recently presenting to my office with ARFID,
Mm-hmm.
individuals in their 60s and up to age 70, I've seen recently.
Wow.
Some of them, it was a more recent thing, and some of them have been struggling with this for decades, as long as they can remember.
And now they're finally in a place or found you in order to try to reduce their symptoms?
Yes. And
Wow.
I think it's because it's finally being talked about, it's finally being acknowledged as an issue, and people aren't suffering in isolation, wondering what's wrong with me.
Wonderful comment. And that's true about so many things. I see it with adults with ADHD that realize I never got treated for this and it really gets in my way. I want to do something about it.
Right.
So the conversation we're having and that we're seeing more of is purposeful so that there's more awareness and maybe more screening and people have more options to look at how to get help.
Exactly. Yeah.
So we talked a little bit about the trends. Are there any demographic trends or any other maybe at-risk factors that you've noticed that tend to stand out? And we're not looking at textbook, we're kind of looking at our experiences here, I would say.
Yeah. So anecdotally, I mean, I don't have any statistics on this, but just in my own experience recently, I've been seeing such an increase in clients presenting with ARFID due to an adverse event, such as choking or aspirating, or maybe they got super ill and had an issue with vomiting. So recently, that seems to be a major increasing issue. I don't know if that's just my own personal experience or if that's across the board with other clinicians. And I find that it's actually increased quite a bit since COVID, that particular type of ARFID.
Yeah, I see that too, Jamie. And I see that whatever starts as the event, like you mentioned, it might be gagging or choking, it often turns into a global fear. And that global fear is sort of like the world's not safe. And maybe that does bend towards some of the fears that came out during COVID.
Right? They can be definitely connected. And it's interesting too, because now I'm not only seeing individuals with ARFID who are struggling with the food issues, but also liquids. They are
Mhm.
struggling to drink liquids for the fear of aspiration.
Yeah. And these are such basic needs to get water and to get food, and yet their body's resisting.
Right.
It's visceral and physical almost more so than what we see in the anorexic side, which is more the cognitive. Though this has a cognitive piece too, of course. The fear becomes its own entity, right?
Right. And the fear can manifest in some actual physiological responses that make it difficult to swallow. And then it becomes
Mhm.
almost like a self-fulfilling prophecy. You know, you think you're going to choke, you think that it's scary to swallow something because you might choke or you might vomit. And then all the muscles tense up and it makes it very difficult to swallow. And then maybe you do actually choke or aspirate or gag because all those muscles are tense. So it just keeps getting reinforced.
Yeah. And when there is an issue, esophagitis or something that is there in the beginning, it's so hard to understand that when there's not pathology in a part of your body.
Right.
And we're talking a bit about the type of ARFID where an event brings it on. But you mentioned with your daughter, there was the sensory. There are people with ARFID who have a sensory aversion or hypersensitive integration, and that keeps
Right.
them from wanting to eat certain foods. Was that the category your daughter fell under, or was she sort of a combination?
I think it was in large part sensory,
Mm-hmm.
both the having an aversion to different types of foods and the way that they felt and tasted. And then also just the lack of ability to read her own body cues and the lack of ability to sit still long enough to listen to the body or to engage in what she perceived as the boring task of eating. So I think it was a
Mhm.
combination of all of those things, but the sensory piece was huge.
I would think a lot of parents could listen to this and go, oh, yeah, my kid doesn't sit down and eat. But again, we're asking them to go back and look at the bigger picture. What is it affecting? What is the impact? Where's their nourishment, right?
Right. So in my daughter's case, it got scary because she was born at the 25th percentile for weight. And throughout the first year, she never really was a good eater. She was always very distracted, never really got full, but she slowly kind of went down to 15% percentile, then maybe the 10th percentile. Then after her first year, when we were really moving on to solid foods from year one to year two, and into year three, she completely fell off the weight chart and was below the 0th percentile. She wasn't even on the weight chart. So
Mm.
then I started getting alarmed. The doctors started getting alarmed. She went through all kinds of testing. We ruled out anything gastrointestinal, any other medical issues. Such a scary, scary time for me. And
Mm.
then when finally all of those things were ruled out, the doctors said, well, it's just something psychological and behavioral that she's going to have to overcome. I was referred to just a general psychologist who really wasn't an eating disorder therapist and didn't really know much about any eating disorder issues, including ARFID, because back then it wasn't even part of the DSM.
Good point.
It was a really tough, isolating, scary time as a parent. And I felt very alone. And I felt like, what am I doing wrong as a mom that I can't get my child to eat and that I can't get her to gain weight? And as a mom, on the most biological, instinctual level, I think when your child isn't eating and you see them just losing weight and she felt like skin and bones to me, then it's terrifying and you
Yeah.
kind of blame yourself. You feel like I must be doing something wrong. And everybody would say to me, and this is something that I think we hear a lot, I even hear from my clients, everybody would say to me, she'll eat when she's hungry, but she didn't.
Right.
Or she would just eat enough to survive. She would just eat a couple of bites of something, but not enough to really be truly nourished and grow and thrive. So it became very scary, very lonely, and there was a lot of shame for me as a mom until I started to really kind of experiment on my own and figure out things that actually worked. And then things became more open and talked about when it was added to the DSM in 2013. And so slowly I started to hear about other cases and felt less and less alone.
How interesting and difficult for you to look at a set of symptoms in your child, know what you know, anyways, as a clinician, have no answers, but then watch it start to transform, make it to the DSM, come up with interventions. That must have been a really daunting, but also hopefully inspiring journey for you.
Yes. As soon as I started hearing about some of the treatments that were being talked about and worked on in clinics, they were things that I had been doing with my daughter anyways, things that I had sort of discovered along the way just by trial and error that worked. But when I heard about those things actually becoming a part of treatment and being researched and being put into practice, and when I heard about treatment teams forming that had therapists and dietitians and occupational and speech therapists, I remember just having the most emotional moment. Like you said, it was kind of a mixed emotion moment. I became very tearful and I thought, I wish this had been there when I was struggling, when my daughter was little. And I'm so happy that other parents might not have to go through what I went through.
Absolutely. That's why your voice is so important and the work you're doing right now. Did they clump her symptoms under like a failure to thrive or one of those categories that,
Yes.
which is a nightmare for a parent?
They said, yep, she was labeled failure to thrive.
Mm.
When she finally made it back on the weight chart, I think she was maybe 5 or 6, and she was like at the 1st percentile. I mean, it was the best day. But the doctor basically said, as long as she stays on the weight chart and stays at that percentile and doesn't continue to lose. We're happy. This is
Yeah.
good. We're moving in the right direction.
Wow.
My expectations had changed over time, but it was hard to hear as a parent, to your point, the words failure to thrive.
And our language becomes different. You mentioned that people were like, oh, they'll eat when they're hungry. But when there's a clinical disorder, those isms and statements, they don't apply. There's something else in the way.
Exactly. The same rules don't necessarily apply for kids who have these types of struggles. So
Yeah.
I think most kids are born intuitive eaters
Mhm.
and they can really tap into their intuitive eating. And most parents don't really necessarily have to worry about their child becoming malnourished because they will eventually eat. But there
Right.
is this subset of our population who does not follow that set of rules.
And yours presented earlier. And I wonder how many other children have presented earlier and been misdiagnosed.
I've actually heard of a ton. And in fact, I forgot to mention this is another comorbidity. My daughter, she was born with acid reflux. So from very early on, eating was unpleasant. It didn't feel good. And we were always struggling to find the right dose of medication to treat the acid reflux. So she struggled from very early on to eat because of the acid reflux. So
Yeah.
I hear a lot of my clients' parents or my clients say, yeah, my son or daughter has never been a good eater. They were born early, or
Mm.
they had acid reflux, or they were colicky, or they just really had a difficult time being soothed. So I hear a lot of that stuff. The underlying signs of this existed really since birth for many people.
I hope one day we see it in the what to expect when you're expecting first year books. You know, those books that,
Right.
parents like, what could this be? And maybe somewhere in there that shows up.
Right. And maybe some preventive work to teach parents, the signs to be looking for and what do you do if you see these things so that early intervention can actually occur.
Yes. And we'll be talking about that, how important in anything early intervention is. We're going to take a really quick break. And then we've opened up so many wonderful areas. And we're going to start to look at the actual treatment, what we do, and where we get stuck, and what's out there for people in our community. We'll be right back. Hello, welcome to Brain Freeze, a multimedia skill tool for anxiety and stress management. Chill the mind, train the brain, and reduce anxiety. Also, check out videos of our episodes on YouTube. We are back talking about ARFID and looking at it from both a personal and professional perspective. I think we're up to, Jaime, talking about what kind of treatment approaches you use or you think are considered effective when it comes to ARFID.
A few things. And I will start with the idea that I very much believe in not using a one size fits all approach. I'm very much the type of therapist that does everything very individualized. If you asked me to show you from step 1 to step 10 exactly what I do with a client that has ARFID, I couldn't do that because it is individualized. But that being said, there are a few things that I think really work and are a part of most of my treatment plans with individuals with ARFID. So one is doing exposure therapy. So food exposures. We kind of create like a food hierarchy. We look at the different types of foods and all the different categories of foods, the food groups, and we list out a bunch of different foods. We list them in green foods, which are their comfortable foods. They're foods that they eat probably pretty frequently or daily. There's no issue with those whatsoever. And then there are the yellow foods, which are, I'm uncomfortable with this. I really don't prefer to eat these foods. I think I might be able to tolerate them if I had to, but I'm pretty uncomfortable with it. Or I think I could learn to tolerate that food, but I haven't necessarily tried it yet. And then there are the red foods. The red foods are the list of foods that the client is absolutely has an adverse reaction to. They just can't imagine ever eating those foods. So we list out all of these foods. And then when we list out those foods, we look at of those foods, how high is your anxiety for each of these foods on a scale of 1 to 10? And which foods could we start with? So with the yellow list, we might pick 3 foods that week that the client is interested in doing an exposure with. And I always want the client to push themselves so that they do feel slightly anxious, but I don't want them to push themselves so hard that they become overly anxious and have panic and then end up regressing. So there's this nice window of anxiety that we shoot for. You have to get a little bit uncomfortable in order to grow, but we don't
Right.
want it to turn into panic. So that's kind of what I shoot for. And I tell the clients right off the bat, that's what we're looking for. So if it becomes too much, just let me know and we're going to dial it back. We're going to figure out a different food or a different way of doing the exposure.
If I can interrupt for a sec, Jamie, when
Mhm.
you set these up, do you also provide some soothing tools or regulation tools to approach these foods, or do you kind of just let the body do what it does?
Yeah, so I do simultaneously as we're doing all this food work, I'm also teaching techniques of relaxation, deep breathing, breath work, mindfulness activities. Sometimes during the exposure, it's okay to have distraction. And again, that's sort of a case by case thing. There are some clients that I can push to be mindful while they're doing the exposure and to be able to observe the food with all of their senses and be in the moment with that food, and that works great. For other clients, as we kind of experiment with what works and what doesn't, distraction is the only way they're going to get that food down. And then the hope is that over time, we can minimize the distraction and become more and more mindful. So, yes, there are definitely tools that we would teach simultaneously in order to make sure that they can tolerate these exposures. I also really do some work on what is an exposure because it doesn't mean that you have to eat the whole plate, the
Mhm.
whole piece of fruit or vegetable, the entire piece of meat. It could be a bite. It could be a lick. It could be a nibble of a food. It could be that you just touch it to your lip or your cheek. Picking the food up and examining it and smelling it, those are exposures. So we want to just keep moving down that path of exposures until they can actually take that bite, until they can actually start taking several bites, until they can actually finish what would be considered a normal portion size.
And this shows that you are what you mentioned before, one size does not fit all. So you have a flexibility that bends towards a client in the moment and where they're at.
Absolutely, absolutely. And when I work with them, I want them to feel that they are in charge of their treatment. They're in charge of this process. They can say when this becomes too much and they need to dial it back. They can say which foods they want to start with. I'm not prescribing foods to them. We're talking about it together. I might have some suggestions based on things they like already, things that would be considered food chaining, foods that are like the foods that they like,
Mhm.
have similar properties and qualities, but they are ultimately the ones making these choices. And I think for a lot of our clients, that is a huge piece of the treatment is knowing that they are in charge of their treatment.
Yes. Some people, I have one I'm thinking of a client that came to me. He's an adult now, but he was quite traumatized by an experience he had with feeling unsafe and forced into a food exposure in a setting that was not ARFID aware. So for him to be able to push himself and to be able to get through that was really important. Meaning, too, that I'm going to guess for you, the relationship matters for your client to feel that they can trust you when you say, come on, I think we could try this.
Absolutely. They need to be heard. Many times in their lives, they come to us and they have had years of feeling unheard, not believed, and people trying to force things on them that they just simply couldn't do. I heard the analogy if you ask a person with ARFID to eat a food that it's a food that would be on their red list, a food that they just can't even imagine tolerating. It's like asking us to eat a plate full of rocks.
Yeah.
We just can't imagine doing it.
Yeah.
And you would be like, no way. It's not that I don't want to, I just simply can't. And
Right.
that's how our clients with ARFID feel. And so we need to make sure that we're acknowledging that and that we're hearing them and that we're meeting them where they're at.
Now, I have a question about this because I love this approach and I think it's what we hear too is the best practice. But because we know that has to be consistency and we have to build this over time. What do you do when somebody is medically fragile or they come? We have clients sometimes that have a feeding tube. How would exposure therapy work in their cases if things can't be as slow? How do you approach that?
First and foremost, we need to make sure that we are reaching out to their medical team or
Mhm.
that they are advocating for themselves in their with their medical professionals on their team that we are making sure we have all of those issues addressed and that they're under the care of somebody that knows what they're doing. And we do see a lot of clients with GI issues,
Mhm.
allergies, food allergies, other medical issues that definitely could be contributing. We want to make sure that those things are being addressed and we're not just pushing this treatment and not looking at the other medical issues. And with clients who are maybe more medically fragile because they're so malnourished, with those clients, it's tricky. I mean, sometimes when they're really medically compromised, they really do just need a higher level of care than what we can do on the outpatient basis. They need around the clock care. They need to be monitored. They need every meal to be monitored to make sure that they're getting enough calories just to survive. So we do need to make sure we're watching that piece and that they don't continue to decline and then have health issues. And then I have seen clients actually with feeding tubes before, and it's definitely not, the first line of defense, but when it needs to happen because somebody is malnourished, we have worked with that before and
Mhm.
they've been able to reduce the amount of tube feeds that they do throughout the day because they're able to increase their nutrition by working with us and by doing exposures.
Yeah, I just had a 10-year-old who that was a source of nutrition so that her brain could be fed enough and her body so that she had the stamina and the ability to do the exposures.
Exactly. And some of my clients say when they got that tube, it took the pressure off. They were
Mhm.
so anxious about being malnourished and not being able to do what they know they needed to do to keep themselves going physically, that the tube took that away. And when that anxiety was decreased because they knew they were getting nourishment, they could then do the work we needed to do in therapy with the exposures. And they have very much been exceeding expectations and moving along very quickly since the tube came into the picture.
That's great to hear that. So we're sort of looking at a tier. Here's who should be involved. But when you're at the outpatient level, we're still watching and we're still making sure that your medical needs are being met. And I'll add to that, we always rule out biology. So no matter what, we always depend on that GI team and that PCP team to make sure there isn't a gastrointestinal issue or something that we don't know about. And once we know it's not that, then we can proceed pretty aggressively with the exposure therapy in a kind way.
Yep, right.
So you do the exposure therapy, and something you and I have brought up, you do that with your client in session.
I do both. Sometimes we'll do it in session. I'll have them bring something to
Mm-hmm.
session and we'll talk through what an exposure looks like and I'll kind of support them along the way. But the bulk of the work is actually done outside of the session.
Yeah.
So, because I'm only seeing this person once a week,
Mm-hmm.
usually. So, in order for exposure therapy to really be effective, it needs to happen as often as possible, at least several times throughout the week. I would say minimally 3 times throughout the week. And if they can do more, even better. Because the brain really needs to habituate to that food, to the texture, to the taste, to the smell, to all the properties of that food. And in order to habituate, it needs to happen with more frequency than just once a week in the office.
Agreed.
That's really key is I'm really just teaching them how to do this on their own outside of this session.
And then that way they'll get more of the agency you talked about, but also more progress because they're repeating.
Exactly. And then my work in session with them going forward really becomes more about processing how did the exposures go this week? Tell me about your experience. And then how can we tweak it for this coming week? What exposures can we do? Can we add on different foods? Can we do these foods you've already tried in maybe a different form, different times, different locations? Maybe we can increase the volume a little bit. Then we're talking about other strategies, like maybe we could pair it with foods that are very much comfortable for you, that you feel safe with, so that it
Yeah.
becomes less scary. Maybe we can work on some breathing exercises before and after. And so we're kind of tweaking things when they come back to see me because they're really doing most of the exposure work outside of session.
And this is so important. I have someone I've worked with, and he's amazing and he's come so very far. He has some comorbidities, though, that make it difficult for him to do the work outside of our time. And when we're sitting down together, he has amazing discoveries. He just discovered that pasta has a flavor that he has a way of describing as starch. And that's fascinating to someone who's eaten it their whole life and to listen to this new person's story about a food. But he can't translate that into his day-to-day life, he's learning his profile, he's learning what his resistance is, but we have such anxieties and some avoidance that gets in the way. So I think what I'm getting at is a lot of times for me, ARFID becomes not about the food, and then it becomes about this whole other aspect of them that's in the way, and that becomes its own journey in and of itself.
Right. There are a lot of other symptoms that we discover along the way, and there's a lot of other issues that, ARFID, it is just one symptom sometimes of a bigger issue that's going on that we're also addressing simultaneously. I always say while I'm working with individuals, I'm working kind of on the surface level with food, but at the same time, I'm also always working on a deeper level on some of the other deeper issues that are going on in their lives that are also contributing and related and important.
So that makes this kind of work hard, doesn't it? We can't really stay in one zone. We have to be so intuitive about all the zones that are going on at the same time.
Exactly. I think part of the session needs to be dedicated to food, but I also make sure I'm reserving part of the session to talk about other things that are going on in this person's life as well, because they are both important.
Absolutely. Looking outside of what we do, and you mentioned a good point, we do an hour, maybe two, if you really have that time to see a client a week. We in our practice have started to talk a little bit about speech therapy, occupational therapy. Are there alternate ways to get at ARFID that fall outside therapy that you have heard clients have had success with or could be promising?
I have recently heard of a lot of successes with speech therapy specifically. Some just tools that sometimes speech pathologists can offer that we don't necessarily know as mental health therapists, things that are more physiologically related to swallowing, strengthening the muscles in the throat, some of those types of things that can maybe be a good add-on to the work that we're doing, and we could really work together. In my ideal world, we would have a speech therapist, an occupational therapist, a psychiatrist, a dietitian, a doctor. We'd have a full team of
Acupuncturist.
people. Exactly. Somebody who does more the holistic stuff. We'd have a yoga person. I mean, we'd have a full team.
That would be the perfect world. And people who aren't making progress, we look in those areas, right? We keep going back and saying, where are we missing? What's another layer for you?
And if we could have all of those layers at once, that would be wonderful.
It would be. And maybe what you were saying earlier is when somebody's very acute or they're not responding in outpatient, higher level of care may potentially have more of those options, at least in one place, which is where you talk with your provider about that next step.
Right.
I think the GI medical approach, because if somebody has a lot of stomach issues, sometimes they'll be treated for that, like you were mentioning your daughter with acid reflux. So I suppose that is another, the GI team might be able to provide some things to alleviate discomfort too.
Absolutely. And I see that frequently across the board with our ARFID clients as well as with our other eating disorder clients that sometimes eating can be very uncomfortable and GI can be a huge help in that area.
Yeah, it really is. It's such a team approach, maybe even more so than some of the other disorders we work with. And
Yes.
then when you have a younger person, you're dealing with other issues in school support and things of that sort too.
Yes, for sure.
We're kind of opening up how the world looks at ARFID and how we interact. And are there the areas that you found that there's misconceptions or assumptions? And this might be true for your personal story too. What do people have wrong? Like what's kind of related to
Mhm.
ARFID that you've discovered or heard through your clients?
So I guess two things really come to my mind. One is, and I mentioned this earlier, is they'll eat when they're hungry when
Yeah.
we're talking about a child. And I don't think that's necessarily the case for our clients with ARFID. The second thing is sometimes I've heard of other treatment providers saying that this person really kind of, how do I word this? They did the treatment to the client instead of with the client, that the client did not have the ability to say, no, I'm not going to eat that. I can't eat that. That's too much. This is what I can tolerate. So when we're treating other eating disorders, I think oftentimes we have to be a little bit more directive in our approach
Yeah.
when they are brain starved and underfed. And that works at first. And then, hopefully as time goes on, we're less and less directive as they are less brain starved. But with our clients with ARFID, that just simply doesn't work. So a lot of our
Right.
clients have come to us with actually some trauma from
Mm-hmm.
past treatment with individuals who didn't necessarily understand ARFID and were treating it like we would treat anorexia, and were being more directive and forceful about the treatment. And that actually ended up complicating the issue and making things worse.
I know we've talked about before, we have had clients with ARFID specifically who have gone to higher level of care. It's getting better. There are places that specialize, but if you go somewhere that doesn't specialize, you're going to get that more directive, authoritative approach, and you might come out worse than better.
Exactly. So if you need to go to a higher level of care, it's really important that you ask very specific questions, not just do you treat ARFID, but exactly how do you treat ARFID, and ask some really specific questions about what do meal times look like? What does the menu look like? What type of treatment do you do outside of meal times? And to really get a good gauge on what's going to happen when I go.
Yeah, I mentioned in the information podcast about this that persons with ARFID are at a higher risk for getting other eating disorders. They already have some at-risk factors. So there's also exposure concerns and protecting them more globally from other eating disorders.
We see that frequently where it starts off as ARFID, and then along the way, probably for multiple reasons, they end up developing another eating disorder on top of the ARFID. We also see people who have anorexia but have ARFID features to their anorexia. So it's a whole mixed bag of different symptom presentations, and they all really need to be looked at very individualized and unique to who that person is and how they're presenting.
And again, in a specialty, you and I and our team have worked studying and collaborating on eating disorders. We have a specialty in it, and not everyone in mental health has that. So find someone who really knows and understands eating disorders.
Yes.
Going back to what you said too, which was so insightful, is that we can't push the same way. Exposures have to come with a lot of agency from the client. I almost think of it, there's an edge. You get to your edge and you have to know where that is, and you don't go past it. But sometimes it's okay to get real close. And you said that, where I'm a little uncomfortable, but I'm still okay. And it takes a good team to know what that is and to go just that far.
Right. And it takes a lot of trust between the client and the therapist. That the client has to be able to trust the therapist to listen. And the therapist has to trust that the client is being open and honest about how they're feeling. And so there's a lot of communication that goes on between therapist and client in this situation to know where that edge is, because that is absolutely a good point. And it does, hopefully over the course of treatment, the edge gets further and further out.
Yeah.
And then as you go along, the beauty of this is it's really hard out of the gate. It's tough. Exposures are slow. You feel like, how am I ever going to get through this? How am I ever going to eat normally? This is ridiculously slow and painful. But then as time goes on and you start to have some wins under your belt and you have more and more exposures under your belt, you gather momentum, you gather confidence, and it starts, the process starts to quicken. And then pretty soon you're adding many things each week, and you're getting excited about it, and you're excited about trying all these new foods, so that there's like this shift of fear and discomfort, and it's just so difficult to, now I'm excited and I'm growing and I see this working. I'm now full speed ahead.
I have to work this into probably every podcast, is neuroplasticity. You have just taught your brain new food, new flavor, new habit, and it remembers and it builds an algorithm, and it makes it easier next time. That's just good old fashioned science.
It really does. And then we can take what we've learned with food and we can apply it to other things outside of food in our outside world. Because most of our clients also have anxiety issues. They also have other issues outside of the eating disorder. And so we can take our successes with food that we've learned and these great exposures and tackling things and knowing where your edge is, and we can apply that to other things.
That was like the power statement of this podcast. It was perfect, because so much of what we do is about how does this affect you as a whole person? Where else does this improve your experience? And that was a beautiful way of showing how that the work is worth it, right?
It is, yeah.
Kind of getting into what works then. What do you see as maybe a trait or something about your clients? And I think this could be true for your daughter too. What tends to make it easier for people to succeed?
I would say support. I would say having people who are willing to listen and talk and understand and hear your perspective having meal support, whether that's somebody to distract you from the fact that this is a really uncomfortable exposure, or
Hmm.
whether that's somebody to sit with you and discuss what you're eating and look at the different properties of what you're eating and talk to you about it from a sensory perspective, or even just somebody to encourage you and celebrate your wins with you. But I just think having support is huge.
Yeah.
And being able to be open with family and close friends about what you're doing, because then there is an element of shame. But when you can be open about it, shame can't grow in darkness. So when you can be open with your family and your friends and you can talk about it and work together as a team, that really is a huge indicator of future success.
This might be a leap, but could that be why maybe at least I've seen some pretty good progress with young people because they're already built into a support system. They have their parents and a lot that's there, whether they want it or not.
Yeah, there's layers of support there. You know what, from school counselors to the family, and definitely lots and lots of layers. So I think that it is helpful. Another thing that we've been talking about a little bit too on our treatment team that is helpful is if you can find the buy-in, if you can find something that the client is excited about, I want, I want to push through this. I want to engage in treatment and make myself uncomfortable in order to grow. And so it's helping them find that why. So there has to be a motivator, whether it's, I just want to be able to go to a sleepover with friends and not feel anxious about what the food situation is going to look like. Or I want to be able to go to that business dinner and not be super anxious about what I'm eating. So there has to be something that you can tap into with the client
Mhm.
that they feel like this is why I'm motivated for treatment.
Yeah. And I love the idea too of an internal and external motivator. Some of those are external. And with young people, we might use more external rewards, but then there's that internal, like you mentioned earlier. What do I take away with this? What does this do for me as a person moving forward?
Right. Right.
Yeah.
How will my life become richer? What will I be able to add on to my life because I'm doing this treatment?
Yeah. And learning distress tolerance. Our clients have to go through so much of that to eat the rocks, as you said earlier. What a gift of a skill to be able to do that and sit in that discomfort and rise above it.
Exactly. And if they can come away with that confidence because now they know how to manage distress tolerance, that's again something that they can apply again and again throughout their lives in a variety of situations.
It doesn't expire, it doesn't have to be in a book. You get to keep it.
Exactly.
It's yours. Anything else that was marvelous in your journey or your daughter's journey? I think what you said is you can call her recovered.
I marvel today at watching her eat because we went from she would maybe eat a handful of chickpeas and then run off and I couldn't get her to eat again for hours to now she'll sit down, she'll eat a whole steak, she eats guacamole, sushi, vegetables, everything you can possibly imagine. She's a better eater than most kids her age, than most adults I know. Like this child will eat almost anything and she's willing to try almost anything. And I think it's just because we worked at this so hard for so long and she built so much confidence. And we use the language in our house. You have to take a no thank you bite, even if you don't like it. And your palate will get used to it. You have to habituate to it. And she kind of gets excited about that now because she realizes how much she enjoys eating because of how she pushed herself through that stuff.
I love the no thank you bite. Does that mean that you don't just default to no thank you? You at least try a little bit?
Hey, even if it's a nibble, you just try it. And if you hate it, that's fine. I don't care, but at least you know, at least you tried it. And you can say, no, thank you. I don't want any more.
And it builds a mouth story. With my one client, we've done this for so long. His mouth has learned a story. And even if that story is, I don't really like that food, he's learning flavors and colors and designs of food. His brain is learning about food. And that happens behind the scenes.
Yeah. My daughter, she loves to cook. She loves to experiment with food. I mean, she's excited about food now. So when I look at where she's come from to where she's at now in her 12 years of life, it gives me hope. Whenever I feel like a client is struggling and I'm like, gosh, they have a long way to go, I remember my journey and I know that there's always hope. There's always hope that they can continue to grow and gain momentum and work through this.
That's a great story. And congratulations on that. And also to your daughter for picking you as a parent. She did a good
Oh,
job.
thank you.
It's like, which parent will be well suited for the needs I have?
I have learned so much from my kids. They have definitely taught me a whole lot and made me a better person and a better therapist.
Yeah, I mean, you can't help but borrow from your own experience. And that's beautiful that you can do that, especially now that you're in a place where you can look back a little bit.
Absolutely.
Anything else that you would suggest is helpful or marvelous or enhances the treatment process?
I think the only thing I haven't necessarily touched on is when you're dealing with kids or maybe spouses with an eating disorder, I think it's important to give the other family members support. So maybe it means getting another therapist involved, one for the parent, one for the child. But I think,
Yes.
especially with kids, the parents are exhausted, they're
Mm.
burned out, they have lost confidence in feeding their child, and they need support, they need coaching. So the work is both with the child and with the parent, making sure that we're also providing empathy and support and letting them know, like, yeah, we hear you, we get it, we know this is tough, and that we hear them as an individual, we hear their story. That's super important.
I think somewhere in my scribble notes, I wrote that down. And I'm so glad that you came back to it because it's a village, whether it's a spouse or a parent or a friend. The other person that's dealing with this is kind of helpless, right? Your hands were tied when your daughter couldn't eat, and you needed to take care of your own self, I'm sure, to get through that.
It is so painful to watch. And so to have somebody to talk to about what you're going through as a parent or a spouse, I think is really crucial to the treatment.
I don't think I've worked with anyone, and I'm thinking of my adult clients too, who just have close relationships with their parents still, who I haven't made a suggestion or who have not chose to get some help for themselves. The other thing I wanted to mention here, and maybe this is true for all persons with this, but there can often be a behavioral collateral piece of this because when we're no, we can't do something, when we're struggling with the symptoms, when we feel like you mentioned the shame, we can act out. And depending on where we are in the developmental stage of life, we might act out like a tantrum or we might act out by being irritated or angry. That's a lot for the other person to absorb and to have to deal with. So often you'll see not just I won't eat, but sometimes behavioral stuff that the family has to contend with.
That is so true. It's really tough as a family to deal with maybe some resulting tantrums, maybe some pretty terrible things that your kids might say to you at times. Kids can say some things that just punch you in the gut, but it is important to realize it's easier said than done in the moment. It's important to realize that all behavior is communication. So if the child is acting out, if there's some things going on behaviorally, it's because there's distress there, there's something going on that they don't know how to articulate, there's something going on they don't have the skills to cope with. So that's another area of therapy, is to give them the skills to say in healthy words what they need to say, or to find ways to cope with that distress.
Beautiful. And I'm thinking of an adult client I work with. This isn't just children who get so overwhelmed and the way she acts out, she does not want to, and she's working on finding a better way. So I love that. All behavior is communication. That is a embroidery on a large Afghan somewhere or blanket. That's a beautiful statement.
Yeah. I think I took that from Dr. Ross Green, the collaborative problem solving approach,
Yep.
which that's The Explosive Child is one of his books, and Raising Human Beings. So I borrow concepts from that quite a bit
Yeah.
in my work as well.
That's a great resource. I think that should say the explosive person because it's not just a
Yes,
child, right? We can
it's
all,
applicable to everybody.
right? We all have our moments where we're dysregulated.
Yes.
You've given so much great advice and information here, but is there one thing that you think stands out that if a family's listening or a clinician that you would say, hey, here's this, just make sure you do or follow this? What would you say?
I think just making sure you're finding a provider that understands this, that gets what ARFID is and how to treat it. That's huge. I think that's it's one of the biggest pieces of the puzzle. And then maybe seeking out support groups. I think things are starting to pop up now that this is an issue that's really starting to be talked about and recognized more. There's online support groups, Facebook support groups. There's probably,
Yeah.
a lot more out there that none of us even really know about that we could tap into. But I think support is a huge piece as well.
Yeah, I have a couple of client parents who have found, I think Facebook for sure, and some other resources where they're in a group now, and this is what they talk about. So you may not have had that with your daughter, but I do
Oh,
think it's
no.
building.
Yeah, exactly. I see it now. I started joining some of those groups just to get information a few years ago, even though I didn't necessarily need it as much as a parent, but I wanted to learn what was going on and learn for my client's sake. So I think those would have been really helpful.
We are in this beautiful wisdom world where we can share, and a lot of it is free wisdom that we can bounce off each other. And that's such a gift right now. The only thing I would add might just be flexibility. I think that goes across all mental health, but if you can be flexible, what a difference it makes to be willing and to just allow yourself to follow a path that could be helpful. Easier said than done, though,
Yes,
right? When you're suffering. But
yes. Flexibility and individualization are two huge pieces of all of my treatment with every single person.
The last thing I was going to ask you was kind of that. How would you describe your overall approach? Is that part of it, or am I stealing your
It
next
is
thought?
100% my approach is flexibility and being individualized in my approach. That is absolutely how I would describe my treatment across the board.
And I think what I've gotten from you today, and I've known this from working with you, but it's not just the flexibility you expect from the client, it's what you bring to the table too. You're flexible and you are looking at them as an individual as well.
Yes, I am absolutely flexible. And, I found that if I try to be too rigid, if I come in with my own agenda, it gets in the way. I'm not really hearing the client. I'm not hearing where they're at. I am missing really great opportunities. So I don't walk in with an agenda necessarily. I meet the client where they're at and we figure it out together.
I love that. You kind of meet them where they are, and that's where you start the work.
Right.
We didn't really talk about this, but often, at least with disordered eating in general, it's a long journey together. We spend a lot of time with our clients. It's not a quick in and out, get some skills and leave. It tends to be kind of long.
It's very true because there's so many stages of recovery.
Mm-hmm.
And then even once somebody is recovered, then we spend a lot of time doing some relapse prevention work and just some maintenance work. So we're in it for the long haul.
Yeah. So that person matters so much that you mentioned, and also having a support for you and your family, because it is going to take a while to get to a place of full recovery.
Absolutely. And we see this over and over that recovering in isolation is nearly impossible. Recovery really needs connection.
That's the whole 12-step tenet, is you have to have a team and a community. I think we're going to call this podcast ARFID 101 because we're probably going to have 900 new ideas in the next 6 months as we learn and develop. And I think there's still a lot that we can open up. But I love that we shared where it's at, what it is, where we start, and what is working so far. I think that's such a wonderful thing to offer people.
It's so true. And there's so much still to learn, which is very exciting because the journey has really just begun.
Yeah. I mean, like you said, when DSM notices it and gives it an acronym, now we're on our way.
Right. Now we can begin the research and really start having some great conversations around this.
And getting that label that at least drives the idea of symptoms and care, which is what you didn't have initially.
Yes.
Well, I so appreciate you coming in and sharing from those two wonderful perspectives that you bring to this table, and knowing that right now you're actively helping and guiding recovery in your own clients, thanks to the story you've had in your life. It's inspiring, and very much appreciate you.
Thank you.
I'm sure you will be back with me talking about many other things in the not so far future.
I would love to.
Thanks for listening to the Mental Health Spotlight podcast, helping you hold hope on your recovery path.